use Kahoot and we have multiple screens. We're going to keep it simple for this event because there's so much going on. It's just going to be poll questions on screen. So we're going to run through some questions. 4 options will pop up on the screen. We'll give you about a minute and we'll talk you through that. Click one of the options on the screen and then we'll reveal the answer, find out what the general feel is in the room, and then we'll just have a bit of a discussion about the correct response, or the correct answer, I should say. If you have any questions as well about any of the questions, feel free to pop them into the Q&A box. We've got 45 minutes for this session, so not quite the full hour, but we'll still have plenty of time, I'm sure. There are 10 questions coming up to test your knowledge. Hopefully you'll find some new tidbits of information to boost your learning. And let me know in the chat box if anything is going wrong or if you're stuck, but hopefully it should be nice and straightforward. So I'd like to introduce Jamie McClement, who's an orthopaedic surgeon and a musculoskeletal clinician based down in Northampton in the UK. Hi, Jamie.
Hi. Hi, Paul.
Bear with me, sorry, I'm getting a bit of feedback, so I'm just going to fix that because I know.
Yeah, there's a bit of an echo going on. I feel like I'm in some sort of 1990s music video. Guys, if anything goes wrong and it looks like Paul's fault, I'll guarantee you it's not. It'll be me. I probably got some weird microphone going on or something.
I think it is you with the feedback currently. So if you just, can you see the lobby? It might be that you're streaming from the lobby as well. It's playing there.
I can't see the lobby.
Okay, no problem. Let's see then. Let's see if we can jump straight in. Hopefully,
okay. I'll just sound kind of funky.
Yeah, it should be okay now. I think I've fixed it my side actually.
Okay.
So we've got a few hundred people in, so thank you all for joining us. Let's get started, Jamie, then. So if you'd like to start your presentation and get started with the questions.
Okay. Hi, everyone. You're doing well. This is quite a marathon. I would just say this is an awesome event. So thank you to Hannah and the CAM team for organizing it. When she asked me to speak, I was very honored. Then she told me I was the light relief before lunch, so I was offended. You know, I'm a published scientist and a surgeon. And then I saw the rest of the lineup and I thought, you know what, fair play, actually. So hopefully this won't be too challenging for you because I know you'll want to relax and have your lunch in a minute. I'd also like to say thanks to Paul for organizing this. This must be an absolute nightmare. I know how hard it is to get myself on time onto a Zoom meeting in my own house. So to get 50 of us on there, that's quite an effort. So well done, Mean Paul, which is what my kids call him, because he said, while I'm talking, no one's allowed to stream. So instead of watching Frozen 2, they got carted off trying to feed the ducks. So anyway, the brief was a quiz about OA management and the evidence behind PT, physical therapy. And I'm to keep it light-hearted but professional and not controversial. So let's see what I can do. So this is what I came up with. The CAM OA quiz with your host, Jamie McClement. And so I ran this past Hannah and she said, no, that's not professional enough. So I had to do a bit of a rework. So I came up with this, which hopefully will work. Right. Here we go. Who wants to be Chameleonaire? You see what I've done there? Quite funny. So anyway, yeah, this is much more professional and lighthearted and not in any way controversial. So we're going to go through a few questions. The software that Clever Paul is running will mean that you will be able to vote on the answers. It's not a competition. I just want to see how everyone's doing. We can chat about what the answers say. I did finish this talk and then I asked Hannah, I said, you want to check it and make sure it's professional enough? And she said, I'm sure it's fine. And I said, I do have a question. And she said, I am really busy. I'm sure you can manage it yourself. Just come up with the answer and it'll all be okay. So the question was, is this for real money? And I thought, well, you know, it's a special occasion. So I'm sure Cam will honor any money prizes that anybody wins. So well done. You're all going to be winners. So here we go. Question 1 for $500. So, in a recent study by Enomoto and friends, 39.8% of the dogs surveyed had randomly, a random selection of dogs, had radiographic signs of OA. What was the age range of the dogs surveyed? So they took a sample of dogs randomly from their clinic and found out how many of them had radiographic signs of OA. Was it 8 months to 4 years? Was it 1.5 to 6 years? Was it 6 to 8 years? Or was it 8 to 10 years?
Okay, that poll question has
Wow, look at
launched.
that. So we are going for B, 1.5 to 6 years. Is that the answer there, Mean Paul?
So we'll just leave that going for about 20 more seconds because
So
about 2/3 of people have participated so far.
Oh, come on, be brave. We'll only find out who you are if you write something really stupid, and then we'll look you up.
That's an important point, actually. These are anonymous answers, so we won't see who's voted for what. So
and
if
I'm
you're
not your
sure,
boss. I'm not going to be marking your diplomas.
yeah, just feel free to have a go if you're not sure. It's all interesting, and the whole point is to learn from this event, of course. So that has slowed down a bit. I think we've got about 3/4 to 80% of people have responded. So what I'm going to do,
the technology is working.
it is. It's very good. I'm going to end that poll. It's a bit of a mix, actually. So I'm going to share the results so you can see it. There you are. So we've got 28% of people said option A, 47% with the most popular answer was B, 1.5 to 6 years. 21% of people said 6 to 8 years, and a few people said 8 to 10 years, Jamie.
Okay, so mostly 1.5 to 6 years, which makes sense because we all know as clinicians, it is not a disease just of older dogs. Let's see, can I press the button and find out the answer? You went for answer B. I can't press the button. Paul, stop sharing your results.
I have stopped sharing, so you can just close that down.
I told you guys, if anything gets screwed up, it'll be my fault. Hang on.
So if you close that box down, that's it.
Oh dear, guys, you've just lost $500. It was actually 8 months to 4 years old. So I think this is one of those things where we do need to review what we say. We do, and I know Cam is very good at this, saying that OA is not just a disease of older dogs. And we say this, but do we really understand it when we're telling to people? So in my orthopedic service, we do very much see dogs very young with this condition, especially with things like elbow dysplasia. And like the onset of radiographic signs is early, and we'll see it from about 9 or 10 months of age. Now, I don't want to go too much into this because Lascelles and Enomoto will be speaking later, and they are, I mean, really, they're the headline act, aren't they? They're sort of the daddies of this area of research. So that's going to be a great talk. So you're all winners in a way, because you get to listen to them for free. And if anyone's got Duncan Lascelles as their phone a friend, the money is basically in the bank. Oh, God, hang on. Sorry, that's the work phone call. Sorry about that. Professor Lascelles. Hi. No, I was joking. I was being lighthearted. The money's not in the bank. No, it'll be in brown paper bags as usual. Non-sequentially. Anyway, I was going to say good luck. Oh, he's gone. Okay. So yes, they will be talking later, and they will be talking about the research that they've found, the evidence they've found. So when we are very good at saying this is a condition also of younger animals, we have to really, really make sure that we understand quite how young we're talking. Most of this is a result of developmental disease. And so these animals will show these signs very, very early. And we also need to work out that just because they are young, if they're showing symptoms, we can't say, well, they're a bit too young for anything else, which brings us on to the next question. And I'm going to try and press it because I still see your answers in there. Bear with me. It kind of counts when you're getting the answer right. But yes, like I said, you're all winners because Duncan is going to be here with Dr. Enomoto later. So let's move on to the next question without ado. I'm going to have to read it from my cheat sheet here because I can't see the screen. A Vet Compass study in the UK found that what percentage of dogs diagnosed with OA, so diagnosed by a vet, did not receive any analgesia? Was it A, 6%? Was it B, 12%? Was it C, 24%? Or was it D, 50%? So this is animals that have already got a firm diagnosis and are under treatment by a vet.
That has been launched, so we'll just
I
leave
know, I can see it live. It's really cool, Paul. Thank you.
At the end, after I've shared the results, I'll let you know, and then you can just click the little X, and it will, because it's only on your screen, so it will take it off, and then you can see your presentation again.
Right. Yeah, I think it's underneath a different window. I've got, oh, I can press OK on a closed captioning transcript is being generated. Maybe I'll press that. Okay, everyone, if the universe stops, it's because I pressed the wrong. Set up professional audio in audio settings. Can I press that? Cross.
Just the ones I'm telling you. Right, so that's been going for about a minute, and I think that's slowed down. We've got about
Right, here we
80
go.
people have responded, so I'm going to end that poll and share the results for everyone to see. There you are. So 53% of people are saying option D, 50%. Slightly confusing that we're giving percentages of percentages, which is the answer, so I'll try to make it clear.
Well, we're all scientists here. We can do double percentages, can't we?
36% of people are opting for option C, which is that 24% of animals did not receive any analgesia, 12% for B, and 6% for A.
Okay, so 50% of you went for 50%. That's quite pessimistic. Okay, there we go. So 24%, so not as bad as you'd feared. But there's two things to unpack here. I think what you were suggesting was that quite a high number of osteoarthritic animals get no analgesia. And overall, that is absolutely true. And I don't like it. But this is purely of the ones that have had a firm diagnosis from the vet, but still 24% of those. And we're talking about like 200,000 dogs with confirmed OA receive no analgesia. Now, going back to our previous slide, there can be two reasons for this, or three maybe. One is client education, and client education is such a huge thing. The second, I suppose, is vet education, clinician education, because when we get these young animals, it is quite common to see people saying, I think they're a bit young for analgesia, especially non-steroidals. It's a bit young to start. Let's try something else first. Well, my view is, if they're not too young to be in pain, then they're old enough for analgesia. And speaking as a father of 3 crying girls who can't watch Frozen, thanks, Paul, when they were babies, you didn't want to give them drugs they didn't need, but when they had teething problems and they were in pain, what did I do? I reached for the Calpol. So young animals should not be lame. They should not be in pain. And then older, we just got this disconnect. Are we not giving analgesia because the client doesn't want it, or are we not giving it because we think it is not necessary? Are there animals out there with OA with no pain? Well, potentially, if we do a good enough job in other areas, but it is unlikely. So I think that is quite a high result. So it is really a question not just of client education, but of educating ourselves and making sure that if we're not going to give analgesia to an animal, we have to have a fairly good reason for doing that. Okay. So that's what? 36% of you with $1,000. Hannah, it's getting expensive. Just you wait. Let's get on. Let's get on. Getting serious now. Here we go. Here we go. Right. A study from Glasgow University in 2010 showed a significant reduction in lameness for dogs with OA when they underwent what? A, TPLO surgery. B, intra-articular injection of stem cells. C, treatment with more than one analgesic medication. Or D, modest weight loss. A, TPLO surgery. B, intra-articular stem cell injection. C, treatment with more than one analgesic medication. Or D, modest weight loss.
Okay, that's running. There is a clear favourite.
There's a clear favourite. Controversial there.
We'll just leave that running for a little bit longer. We've got about 70% of people have responded. So we've got some fastest fingers in the audience, which is good to see. There's a throwback to the old
If there's any doubt, we can always ask the audience. Maybe best to leave it till they've had all the lectures, and we'll do it tomorrow, eh?
Yeah.
No, you're doing well. You're doing well.
Okay, so that's slowed down a bit. So we'll stop that and share that. Still a bit of a split, but a large favourite in there. Let's share those results.
So final answer. You've gone for D, modest weight loss. You guys know the literature. So let's go through all the answers. A, TPLO surgery. Well, that would work if the reason they've got OA is secondary to cruise ship failure and instability. Yeah, that would work. But I suppose that's a minority of dogs. So that was a bit of a random one. Intra-articular stem cell injection. Well, yeah, that will help with animals with OA. It wasn't the answer. It wasn't what Marshall and that lot looked at. Treatment with more than one analgesic medication. No, that was not the answer. It was, in fact, modest weight loss. And I think this is a major thing because we're often focusing on things like medications and surgeries and lasers and treadmills, and they are all super important. But there is one thing that has massive evidence, and that is if you keep your dog slim and of a correct body weight, then they do so much better with these kind of conditions. And as you all know, because you've all got this question right, that's for two reasons. One is because we've got mechanical overload of the joints. And if these joints are abnormal, then mechanically overloading them will give us more problems. We know that. The second is that we know that adipose tissue, it is, it's endocrinologically active. And so it does set up these chronic inflammatory states. And that can be through, it produces leptin, which we know is a hormone, especially in humans, that can contribute to inflammatory markers in joints that are affected by OA, and adipokines it produces. So it's not just a mechanical issue. Now, this is not also just a case of if your dog has OA and is a bit fat, that you should lose the weight, although that does work. And what they found was it was about sort of, I think it was 6.5 to 10% of their body weight to be lost would give a significant improvement in lameness, similar to giving them non-steroidals. And not as an alternative, you can do both and they add up. There was also that. But then we've also seen these studies where they compared cohorts of Labrador pups. And one group were fed ad lib, and then the other were fed the restricted diet, so 25% less than what the ad lib porky ones were eating. And the incidence and severity of OA over the dog's lifetime in joint conditions was reduced. So when you are talking to young animals, and we keep coming back to young animals, when you're talking to the owners of young animals, even before you get the diagnosis, the first thing you can say is keep them slim, keep them fit, keep them active. And sometimes it sounds obvious, but we are fighting against this idea that to protect puppies' joints, they need to be locked in a box and restricted. And it turns out that's not really the case. I mean, obviously they shouldn't be taken jogging, but I remember, this advice, exercise them for their walks for 5 minutes per every month of life. When I had my pup, we used to put him on the lead and walk him around the park. And to be honest, except for when he was asleep, that was the calmest he was all day and probably doing the least trauma to his joints. In the house, he was a nutter. And you look at canids in the wild, they don't restrict their exercise when they're young. And it is important for joint health that they are mobile, and it's incredibly important for joint health that they are fit. And it is super important that they are slim. And it's an easy sell to clients usually at that stage, because this is something they can do not only for free, it will actually save them money because they're spending less in dog food and they don't spend so much on treatments and the like. So get in that information early, because it's much easier to keep a dog slim and fit than it is to retroactively make them lose weight. And it is also something where we can enforce this through teaching, because it's very common that once you start with an arthritic dog who is overweight, you say they need to lose weight. Well, we know it's difficult, and it is difficult. But also some of the excuses they come up with, like, oh, he can't walk as far because he's got OA and he's overweight. Well, no, that's true. That is true. But for every 100 meters an arthritic overweight dog walks, they're expending far more energy than a fit dog. So actually, it doesn't take much exercise to get that weight cutting down. And we need to do all the tricks that I'm sure you know of weighing out their food, giving from that instead of treats. But I think it is important that we realize this is not just a good thing. This is one of the most important things that we can do in terms of arthritis. Okay. Should we go? Should we move on? Hang on, I lost my cursor there. Don't worry, Paul, I found it again.
Just whilst you're doing that, there's a really interesting discussion going on in the chat box, which I'm not sure you'll have seen with the
No, I
presentation.
can't see very much. I'm rubbish at this. I'm not going to try and find it. You have to tell me.
So yeah, just before we move on, so it's actually about the last question about analgesia.
Yeah.
So Lisa was saying in the human field, it's obviously quite interesting because they're now firmly moving away from most analgesia options for chronic and sometimes acute pain, particularly NSAIDs and opioids. Makes it harder for humans to cope. The reason is the use of NSAIDs can set you up for enduring chronic pain and doesn't actually help you once you're there. And then there's some interesting rebuttals saying with humans, we can address the psycho and social elements of pain better with things like CBT. Don't have the option with animals, of course. So it's slightly different. And
yeah, it is slightly different. And, you know, in humans, there is very good evidence that you can get a lot of your analgesia through PT and through weight control. I'll be honest, a lot of humans start off in a worse position than our patients, that they will be having a very sedentary lifestyle and very overweight. So they've got a lot more benefit from that. Also, humans tend to have a lot more problems with chronic medication because they are, on the plus side, they perceive the pain and the benefit themselves, so they are better at tapering. But humans will be taking the medication for longer and self-medicate, and that's when they can run into trouble. So there are various different ways of doing things. Humans also will be much better at self-restricting when they're doing something that is causing pain in most cases, unless they're a sportsman. So we can't pinch everything from human evidence. We have to pinch a lot because the evidence base for animals in these kind of areas isn't great yet at the moment. It isn't big. It's getting better. So it is important to look at the differences as well as the similarities. So that's a great chat. We might come back to it later if we make you all millionaires before then. Hang on. This is so professional. Paul, are you not impressed?
I'm loving it. I'm loving the little music in the background as well.
Right, next question. Where are we? Once a diagnosis of OA is made, which of the following statements is not true? I usually get confused with this in exams at college. They would say, which of the incorrect statements is not incorrect? And you'd be like, oh my God, I can't get my head around the treble negatives. Once a diagnosis of OA is made, which of the following statements is not true? 1, strict rest is needed to avoid overloading the joints and causing pain. 2, starting a program of strengthening exercise improves muscle weakness and joint stability. 3, I'm saying 3, it should be C. Sorry. See, it doesn't matter so much what exercise is done as long as they do it. D, movement of arthritic joints improves not only range of motion, but also cartilage health. Go.
Okay, that's launched. There's a lot to think about here with some double negatives, but we should be okay. Most people are voting now, so that's quite interesting. So you're looking for what is not applicable once a diagnosis of OA is made.
I'm being sneaky here.
Okay, so yeah, we've got about 60% of people have voted so far, so we'll leave that up for another 10 to 15 seconds just to give everyone a little chance to have a think. Interesting comment in the chat as well there from the last question. A lot of overweight dogs are owned by overweight owners as well, so it can be a sensitive area to discuss.
It can be, and I know this is Britain for most of us, but it is our duty more to the benefit of the patient rather than safeguarding the happiness of the owner there. And I think really telling a bit of truth. And it's very rare that people get offended because we are talking about the dog. And then they will often say, oh, maybe that would work for me. And then I do a big no comment.
Okay.
But you're right. Yes, it can be said. We have to handle it sensitively. So we don't sort of say all creatures that are overweight. No. We sort of say, well, your dog, and there are reasons for this. And if they can draw, their parallels, well, that's kind of up to them. But we must be sensitive. You are right, because they are the caregiver, and we're working as a team with them. But we must address it. It is our moral duty as well as our professional duty. That's what I said in the video. Let's come back to it. Right. Let's go to this question. You guys.
That has slowed down. So let's end that poll and we'll share
the answers here.
Let's go. There we are. So 80% saying A, 6% saying B, 12% saying C, and a paltry 2% saying D.
You're absolutely right, guys. Absolutely right. It's A is not true. A is not true. So we do need to moderate the exercise, but we do not need strict confinement. No. We need to avoid a sedentary lifestyle for these patients, like we were talking about in the last question. So we know that the answers to question D are correct. So movement of arthritic joints improves not only range of motion, because you are doing range of motion for your muscles, which will go into spasm around the painful joint, but cartilage health, because cartilage nutrition is by diffusion from synovial fluid, and the actual pressure of moving and weight bearing on the joints is what gives it its nutrition. So absolutely spot on. The answer was, I didn't do the green thing. It was A. So the other answers there. So yes, starting a program of strengthening exercises improves muscle weakness and joint stability. Absolutely true. So strengthening exercises are different from things like passive range of motion and walking exercises. It's things like sit to stand exercises, which is equivalent to a human doing control squats. So really worth looking into, and this is where getting involved with, or working with a physiotherapist is very, very useful. They don't need to be there for all the exercises, but they can train the owners to do them, the caregivers. And what was the other one? It doesn't matter so much what exercise is done, so long as they do it. This was from a human study. Obviously, this doesn't mean that we can do random exercises that are bad for the patient. But yes, they didn't find a difference between different exercise regimes. It was the fact that exercise was being done, so avoiding a sedentary lifestyle. So that is the important thing. Right, I'm going to move on now, because I'm conscious it's going to be your lunch after this, and you need your traditional online CPD lunch of microwave hot dogs. Make sure you have time to cook them thoroughly. Otherwise, like the CAM slogan says, raw dogs, diarrheas. Professional. Right. Anna, look out. You're going to have to sell your van. Here we go. Next question. My cursor keeps disappearing. Which of the following is not a proven benefit of hydrotherapy for dogs with OA? Which is not a proven benefit. It increases blood flow to the muscle tissue. It allows low impact range of motion exercise. It increases muscle strength, or it gives volume and shine.
Is up and running. That's an encouraging.
Anna's going to be mad now. She's going to be mad. Look at this, 5,000. How many people have we got online at the moment?
There's over 300 in this webinar, plus some people in the lobby.
I'm sure she'll be fine with that. She's like a CEO. They've got bags.
There's a legal disclaimer: no £1 million are being given out on this webinar.
You're quite right, because if you look, you'll notice it's actually US dollars.
It's dollars, yeah. Is the pound strong at the moment?
There we go. Have we got an answer, Mean Paul?
Yes, we'll end that poll and share the results. There you are.
I was being light-hearted, although I suppose, it does give them a bit of a wash. But yes, so the benefits of hydrotherapy, it does various things. The warmth and the hydrostatic pressure will increase blood flow to muscle tissues, which is good, because that's the kind of thing we're trying to achieve with like heat therapy and massage. It is kind of a side effect, but it's a good one. Also, you're mobilizing these joints, so that you're increasing muscle strength. You're doing it in a low impact way, so you're not increasing the stress on those joints. So we're getting what we wanted, which is a non-sedentary lifestyle without overloading the painful joints. So it's a very, very useful technique. Well done, everyone. You didn't fall for that nonsense.
A good question came in actually just then, Jamie.
Oh, Paul, you said something important, but it was covered by my professional music.
So good question came in there. What do you say to people when they say running causes OA? Notice on your professional profile that you are a runner.
Yeah, I did write that maybe a year ago. I've been a bit late. Interestingly, a study in humans. So I did do my master's in human orthopedics. So they did studies of sportsmen, well, sportsmen and women, and they found that although there was an increase in NEOA in certain sports, long distance running, it was not. So humans tend to do things in sports that are a bit stupid, like pole vaulting or, you know, triple jump, which we're not really designed to do. But when you get us to do what we are designed to do, it's just like me, we're a bit lazy. We're playing busy, but a bit lazy. Actually, it's not. So the injuries, the OA tends to come from actual injury rather than the process of running. Dogs are very well designed to run. They are. As Hannah will tell you, there are some things that we make them do that they're not so well designed for. And certainly if you've got an animal with osteoarthritis, stopping suddenly, catching balls, climbing over rocks, things like that, yeah, definitely that's falling into the triple jump ice hockey nonsense. But actually walking and running in a fairly straight line on firm footing, they're well designed to do. So good question.
Is that about also sort of linear motion through the joints rather than?
It can be. They're very well adapted for linear motion. They are able to turn and things like that. But the more linear you can get the motion, the less traumatic it is for them. Yeah. So running itself, dogs will easily be able to outrun you, as I know because I go jogging. It's just embarrassing. Right. What benefit does use of pool swimming have over underwater treadmill exercise? What benefit does pool swimming have over underwater treadmill exercise? So we've got better physiological gait simulation, allows exercise for more severely debilitated patients, variable resistance and range of motion of joints, or selective control over joints exercised. Go. Phone a friend, ask the audience.
Interesting. That has launched. There is a bit.
Can't do 50-50 because I wasn't that good at designing this. I just got it off the internet, guys.
We're not technically proficient for 50-50.
All of this. If I'd asked it, I would have worked it out. I haven't got a clue. I'm just impressed that it's all worked so far.
There's
right, here we go.
Much slower response rate here as well, which
I
makes
know
this is thinking about this one.
This is getting well. We're getting up to $7,000, people.
So we'll leave that for.
They're trickier questions.
15 more seconds. Yeah, a bit of a split between two of them. There is a slight favourite currently. So that's people still voting in big numbers. Over 200 people voted.
Good. Share us the answers there, Paul.
Yeah, we'll stop that now. Then that's slowed down. So let's have a look. So we're looking. Just over 50% of people have gone for B, but 30% of people have gone for
which is
C.
allows exercise for more debilitated patients.
Yes.
Let's see. They're correct. They're correct. So better physiological gait simulation, no. I think that's me putting in the negatives because obviously walking or trotting on a treadmill is a better physiological gait simulation. Variable resistance and range of motion of joints, you can actually achieve that kind of with both. You can use resistant jets in pool swimming, and obviously you can vary the depth of water in the treadmill. Treadmill, you have a bit more control because you can vary depth of water, you can vary angle of the treadmill, and you know that will affect both. And selective control of the joints exercise is the same thing. You can't really do that when they're swimming so well. So well done, everyone. So this is an example of where often we think, oh, underwater treadmill, maybe that's better. Well, it's better for certain things, but it's not better for all things. So this is one of the cases where you would be better with a pool because some of these dogs, even walking on a treadmill with buoyancy, will be very painful for them. So getting the benefit of low impact exercise, sometimes a pool is superior. Cool. Right. We're getting into the big money. Where are we up to? It's dollars. Oh, it's so exciting. Which of the following is a type of thermotherapy? So heat therapy. Which of the following is a type of thermotherapy? Is it A, heat packs? Is it B, low-level laser therapy? Is it C, hydrotherapy? Or is it D, all of the above? Go.
Is launched.
They're quick on the button here.
Much quicker than the last one.
They've all gone for quite a controversial answer.
There is a clear favourite.
Okay.
There's yeah, interesting. Something I'm assuming you will touch on. So I'd give that about 65% of people have participated. So just about 10 more seconds because I can see people are still piling in, and we'll stop that now and share the results. So 76% of people have said all of the above.
All of the above.
19% people heat packs, 5% low level laser therapy. That's a mouthful, and nobody's saying hydrotherapy alone.
Yay! You're so rich, people. It is all of the above. Now, obviously, I was being a bit sneaky. I was thinking of poor Hannah's pension fund here, but you've seen through it, because although it's not always the prime mechanism of action, all of those do use thermotherapy in a way. Heat packs, obviously, because thermotherapy, they are heat packs. Low-level laser therapy does do other things, but it acts in certain ways as a heat therapy. Hydrotherapy, if you use warm water, seriously, if you use cold water, it wouldn't, but I mean, who would do that? So yes, all of the above. And heat has various things. It increases blood flow, and it does actually help in a sort of reduction of so basically it acts as an override of pain. So that is a useful thing for heat therapy. So when we use heat packs, for example, we've used them for hundreds, thousands of years, but we didn't quite realize how clever they were. So they do more than just warm up the tissue and get it loose and ready for exercise. That is one of the things they do. But it does actually provide analgesia. Happy days. I'm going to get a move on because it's nearly lunchtime. There was me worried that we weren't going to be able to string this out. We're doing well. For $20,000. Which of the following, we're going on with laser. I was going to say more, but I thought, no, I'll tell you the answer for the next question. Which of the following is not thought to be a mode of action for low-level laser therapy? A, photobiomodulation. B, analgesia from direct inhibition of peripheral nociceptive nerves. C, reduction in inflammatory substances such as PGE2 in inflamed tissues. Or D, stimulation of chondrocyte regeneration via geonosic kyber enhancement. Which is
okay,
not.
that's running.
I'm doing it again. I'm being sneaky, which is not.
There is one favorite, but there's still a bit of a mix. People going for some of the other options as well. A little bit slower, as we mentioned, so probably thinking about this a bit more. Just 50% of people have voted now, so just give that a few more seconds. Just
They're loving it. They're loving your technology, Paul.
There's lots of comments coming in earlier saying, love this way of learning. So that's good. You're doing a good job, Jamie.
We are brilliant, you and me. Giving out all this money. Hannah, thank you to Hannah for stumping up the money. That obviously is part of the excitement.
Okay, let's draw that to a close then. 200 people have voted, so end poll and share results.
Okay, so we've gone for D, stimulation of chondrocyte regeneration via geonosic kyber enhancement. Did I make that up, or is that really not an effect of lasers? I didn't make it up. It is an effect of lasers. However, it was the laser technology used by the Death Star to destroy the planet Alderaan in Star Wars Episode 4, A New Hope. So well done for seeing through my tricksiness there. So photobiomodulation, yeah, that is a mode of action of laser. That's probably the most. So what that does is it stimulates mitochondria in cells, which you know are the powerhouse of cells. but what it does is it enhances certain cell proliferations, and it can activate anti-inflammatory pathways. So it activates this thing called cytochrome C oxidase. So that is true. That is not woo. That is an actual fact. Photobiomodulation. Sounds like I made that word up. No. What else did we have? Analgesia from direct inhibition of peripheral nociceptive nerves. That's what we were talking about just now. That is the same mechanism. It's believed that when painful dogs see a squirrel, they have a squirrel override, that they're old and creaky, but then they'll see a squirrel and it'll switch off the pain. They'll do it, and then they'll go back to being painful. So that is also an effect. And then reduction of the inflammatory pathways, absolutely true. So useful in things like muscle or tendon inflammatory disease, which also kind of is what we get as a secondary effect of OA. So even though the proof there is not massive for use directly in OA, we know that these conditions exist in patients with OA. So we can use it kind of as a secondary thing. So it is helpful. It is definitely helpful. Heat packs, still massively useful. Why? They're not as good. They don't penetrate as deeply as laser, and they don't have some of these other effects. However, they are only $2, and you can get them off Amazon, and the owners can use them 4 or 5 times a day. So it's not one or the other. You've got a spectrum. Laser therapy is very, very useful, but heat packs should not be forgotten. I rant on about this a lot. Question 9. Oh my God. This is for 30,000. I don't think we're going to get to 1 million here. $30,000. We're on to a different modality now. What is the mode of action of transcutaneous electrical nerve stimulation, which is TENS? That's how it is. It A? I still can't see my screen. I can see the edges. No, what's it when you get the cataracts? You can only see around the outside, the opposite direction. Uses neurostimulation to prevent new sensory nerve production in arthritic joints. Is it B? Reduces inflammation by transfer of negative ions. Is it C? Activates descending inhibitory neuronal pathways to reduce pain. Or is it D? Stimulates muscle contractions, so improving muscle strength and therefore joint stability. It is a difficult question, Paul. You're right. That's because it's for $30,000 for each and every person who gets it right.
It's not a shared prize. It's per person.
Yeah. It's per person.
Good.
Isn't that right? She's listening. She's nodding along, I'm sure. She hasn't said anything on the WhatsApp group, so she's fine.
Missed a trick by making question 9 about TENS, didn't you there?
That's good. I like that. Yeah.
Okay.
No wonder they're confused, Paul. No wonder they're confused.
60% of people have voted, so we'll just leave that for a few more seconds. And we'll draw that to a close now. 2/3 of people have voted, and we'll share those results. So 60% are saying option C, with 26% saying D.
Oh, well, on that note, Hannah has replied, Jamie, I'm watching you and my wallet. It's the bank vault we're worried about, Hannah, not your wallet. Right, so you all went mostly for answer C. Activates descending inhibitory neuronal pathways to reduce pain. Here we go. It is actually that, yes. So similar maybe to what we were talking about before with heat therapy, similar also potentially to what goes on in acupuncture, we're not sure. But the important thing here is that TENS does not reduce inflammation. TENS interferes in pain perception. That's not a bad thing because it is a painful condition. So it's one of these conditions, one of these modalities where we have to think, we have to know what each modality is doing, and then we have to tailor the plan to the patient because they do different things. It's tempting sometimes with physical therapy to think, well, they all kind of work, so let's just do everything for every patient. Well, maybe, but we should be more scientific than that. We should look at evidence and see what do we need, and let's apply what is useful. Why? Well, partly because overtreatment is never useful, and we've got to consider the caregiver burden. You know, all these things cost, they take time, which is a big thing with these owners. But also it's just trying to tailor the treatment regimen to the particular patient. What else did we have? Neurostimulation prevent new sensory, then that's a mashup. A, that's kind of more what Librela does, but without the neurostimulation. B, reduces inflammation by transferring negative. I just made that up. It sounds scientific. Maybe it's right. I don't know. If it is, it's a genius guess. And D, stimulates muscle contraction, so improves strength and joint stability. A few of you put that. Kind of. That was the sneaky bit. That is neuromuscular electrical stimulation. That's when you trigger the muscles to contract, like you do with the thing you buy on online to give you a six-pack. Now, we do use that sometimes in dogs, but that is slightly painful. So usually do it sedated in dogs that are completely immobile so that you can build up their muscles. So it is a form of electrical stimulation, just the other one. You see, Hannah, I'm good to you. I caught some of them out. Now, Hannah's just texted again to say, Paul, because we're running late, we can go straight to the $1 million question. Control your excitement. He's trying to look excited, but as he was saying, it is a hostage video he's in there. Hannah has taken him hostage and is keeping him in a cupboard until this is all over. So people, for $1 million, why are we doing all of this? A, to ensure maximum drug usage across our clients. B, to use up as much of our clients' time as possible. C, to make dogs better, or D, to make loads of money. Go. This is you could lose all of this money now. You go back to like $100 if you don't get this right.
Okay, lots of people voted. We know what the CMA might think of this question, but that's another matter.
They are our sponsors, Paul. Remember that, they are our sponsors.
Okay, most people voted now. Clear favourite, which is good.
Clear favourite. Shall we press the button for the $1 million prize, people? You're right. This is why we're in it. Not to ensure maximum drug usage across our patients, although you would not guess that sometimes. A few years ago, my job was to persuade people it's not just about non-steroidals, there are other drugs. Now I spend more time saying, whoa, hang on, don't give all the drugs all the time. To use up as much of our clients' time as possible. Sometimes it can look that way. So we have to make sure we understand the caregiver burden, because these people, they do have other things in their lives. You know, they get dogs to improve their lives, to make them happier, to improve the dog's life. And we have to make sure that when we're asking them to give up their time to do things, that there is a provable benefit, and the benefit corresponds to the amount of input that they have, whether that's money or whether it's time. D, to make loads of money. No, I mean, I do this and I do orthopedic surgery. And as my accountant points out, this kind of thing is not the stuff that makes the big money. We're doing it because we want to make dogs better. And like I said, you know, dogs do so much for us. And so many of them are in pain that I believe, like I said in my very professional teaser video, it's not just our professional duty, it's our moral duty to try and improve what is a chronic, progressive, painful condition. And you all agree, which is great. Oh no, some of you are going to be investigated by the CMA. 3% of you saying it was to make loads of money. How very dare you? Anyway, that I think is us. But what I would say is I did just have a message from our sponsors, the CMA, and they pointed out that, like you said in the last question, they now have it as evidential in writing that vets are not in it for the money. They're in it to make dogs better, which is what we're doing together. So I'm afraid the cash prizes do not apply. Sorry, Paul.
Amazing. Thank you so
I'm
much.
5 minutes over. I'm eating into their microwaving time. I'm so sorry. I hope that was helpful. Maybe we have time for like one question. I don't know. Or feel free to log off and go for your lunch, people, because you must be starving.
There was a question, and Sarah said she was going to buy lots of land and thousands of dogs with the prize money, but she loved the quiz. Christina was just asking, could you just repeat what you were talking about in terms of Librela reducing inflammation and the scientific?
No. Librela reduces the growth of new sensory nerves into joints. So I was doing a mashup of that and neurostimulation to catch you all out. So that's what it does. Librela doesn't reduce inflammation. You're quite right. Librela is purely analgesic.
And then someone in the Q&A box as well about Librela as well and the anti-inflammatory effect, and suggesting using it with NSAIDs. What are your thoughts?
Yes, well, it's not tested, you know, they didn't do the research with them together, and in humans there is a problem. You can't do it in humans because you can get this condition of the knee where you get this really rapidly accelerating disease in the knee. It's not been proven in dogs. Does that mean it can't happen? Well, there are some questions about whether we're seeing perhaps some faster progression of elbow disease in animals on both. I do use it a lot with both, but with care. And you do have to have a conversation with people. Librela, I think, is a fantastic drug. I think the biggest problem with Librela is it doesn't do what it doesn't claim to do. And people often use it for things that it doesn't claim to help and then complain it doesn't work. But I think it is a brilliant drug. It's made a massive difference to a lot of dogs. But there are some questions that we don't know until we've used it for a long time about, you know, what is the role of nerve growth factor apart from the role that we're using it against. So I do use it in conjunction in more severe cases with non-steroidals. But I do it with informed consent of the owner, explaining why I'm doing it. And so far, I don't have particular problems with that. I don't use them in combination younger dogs. I tend to use, you know, initially I was starting to use Librela in younger dogs. I've moved away from it. I think one question is, you know, in humans, they often try and keep your nerve growth factor levels high if they're worried about things like dementia. So I try and avoid using Librela if there is a neurological condition going on. And I would only use it if I feel that the pain is more of a welfare problem than any risk we might have if we did accelerate the neurological condition, but we don't have evidence that it does accelerate it. So I think just like any drug, until it's been used a bit longer, we just have to think things through and explain them to the clients. So I do use them together in a number of cases, yes. And so far, touch wood, I haven't had major problems with it, but it is important that you explain things to the client. But they do work in different areas, and I think using them as a combination is sensible. But it's just thinking as well, at which point in the disease are we? You know, at the beginning, theoretically, the majority of the pain is going to be from a synovitis. So inflammation, so non-steroidals would be the drug of choice. At the end, a majority of it is going to be this neuropathic pain. And until Librela came out, we didn't really know quite to what degree, but it seems it's a lot. So towards the end, Librela might be more useful. But there's a grey area in the middle. And at what point do they cross over? And when do we switch from using non-steroidals to using Librela? Or is there a time when we need to use both? And I think in all honesty, you have to say, although they're not tested together and there are some questions, it is justified in many cases. So I do. Yeah, good question.
Brilliant. Thank you so much, Jamie. We're going to have to draw it to a close there then. So thank you so much for a very fun and informative quiz. We really appreciate it.
Thanks, Paul, for making it work.
We have a bit of a break. I know we've gone over, so we're going to have a slightly extended break whilst we get things ready for the next talk, and then we'll see you shortly in the next session. Thanks, everyone.
Thanks, everyone. Take care.